Hello, my name is Dr. Don Sin. I'm the Deputy Chief Editor of the European Respiratory Journal. Today I'm joined by Dr. Joan Soriano to discuss his latest editorial on the long COVID series, which will be published shortly in the ERJ. Dr. Soriano is a medical epidemiologist who currently works at the Department of Respiratory Medicine at Hospital Universitario de la Princesa. He's an honorary professor of medicine at Universidad Autónoma de Madrid in Madrid, an associate professor at Universidad de Ciencias Baleares in Mallorca, both in Spain. He has been an associate editor for the ERJ since 2005. Hello, Joan.
Hi, Don. Thanks for having me. And wow, 2005, almost 20 years as associate editor already.
You've done a fantastic job for the ERJ and for its community. Thank you so much. Today, we're going to discuss a little bit about long COVID and the long COVID series that will come up in the ERJ. First of all, why do you think long COVID is important, and what should our audience be aware of?
Well, long COVID is very important. There are several reasons for that. One is that we already know about COVID and long COVID. If you go to PubMed and you type COVID-19, Don, how many papers do you think there are?
I don't know. I'm guessing 100,000?
Multiply this by a number of 4. So there are already 418,000 individual peer-reviewed publications in only 4 years. So this is more than asthma and COPD, and probably with lung cancer, ever. However, the burden is huge. The latest estimates is that probably in between 1 in 6 and 1 in 8 of those acutely infected have some symptoms of long COVID 1 year later, and many of them is an unmet need. So there is a lot of need for new research, and I'm sure that both COVID-19 and long COVID are here to stay as an example of post-viral syndrome. We know about Zika, we know about chikungunya, we know about many other viruses, but this one in particular is a very bad virus, and this is why it is so important.
You see lots of different definitions of long COVID. What are the most commonly accepted definitions by the medical community? And frankly, what should we be using going forward?
Well, in the beginning, especially when there is any new entity, any new disorder, any new disease, there is confusion about 2 things. One is the name, and the other is the definition. So regarding the name, some people, they were saying that this was a syndrome. Others were saying that this was a disease. Other, a collection of symptoms and signals. And at least there were 12 different names and 12 different definitions. The WHO started in 2020 a Delphi example and a Delphi exercise to try to identify the most common symptoms and to achieve a definition. Basically, all the definitions available, starting from the Wellcome Trust or the NIH or the ERS or even other definitions in primary care, state that this is a new disorder that occurs after the acute phase of COVID-19, whether this acute disease is identified biologically with a test or without, especially because in the first waves of the pandemic in 2020, there were no tests available, that usually happens 3 months after resolution of the acute event and lasts at least 8 weeks. The most common symptoms are respiratory, cognitive, or constitutional. And the important thing is that these symptoms cannot be explained by the severity of the acute disease. So these are symptoms that are independent actually, and most of the times do not occur only in those who were having a critical COVID-19 with admission in the intensive care unit, but mainly occur in individuals who happen with COVID-19 in primary care or even paucisymptomatic or asymptomatic completely. But these times of after 3 months, lasting for at least 8 weeks, and that this is not explained by an alternative diagnosis are repeated in the different definitions. Particularly, I like the one of the National Heart, Lung and Blood Institute of the US NIH, that this is a probabilistic definition. And for post-acute sequela of COVID-19, PASC, this group in the NIH came to a group of symptoms, and each of one has a score of 4 to 1 points. And if they reach the threshold of 16 points, this individual is identified as PASC positive. I think that a definition like this, that is probabilistic, can be used in administrative databases and also when you are doing free text search with artificial intelligence, and does not require the identification of the diagnosis by a primary care doctor or any other specialist. And this is a way to move forward, and this has to be validated in other populations.
Are there any diagnostic tests that patients can undergo to confirm the diagnosis? What you mentioned may be non-specific. Are there anything that physicians can order to firm up the diagnosis of long COVID?
Well, as you know, for acute COVID, there are several. For long COVID, not yet. There are tests that are being experimental, specifically searching for a biomarker in blood or in saliva. And there are several individual targeted or even panels of biomarkers, but the sensitivity is no more than 80 or 85%, with a rather reduced specificity. So we cannot say that any biomarker to date in blood or in saliva can be used to screen or to confirm long COVID. Long COVID, as of now, it is still a clinical diagnosis. I'm also looking forward to use things like voice or cough identifiers. There are initiatives that include artificial intelligence of recordings of voice or even actively requesting the individual to cough, and they are trying to separate this from, for instance, other types of pneumonia or bacterial pneumonia or viral pneumonia, and to identify those with long COVID with each one of the main 3 phenotypes that we have for this disease. But as I said, for the biomarkers, not yet. This can be used wholeheartedly in everyone, and all these are experimental.
So in your opinion, do you think long COVID is a distinct and unique disease entity, or is it just a non-specific sequelae of a very bad respiratory tract infection caused by a virus? In other words, any virus can cause, quote-unquote, long COVID.
Well, there is a long-standing debate, and I'm sure that you have your opinion, I have my opinion. I remember in the 80s and 90s with HIV and AIDS, it took most of a decade to identify the name for AIDS, and also it took 6 years to identify the virus and the markers of the virus and the markers of the definition of AIDS. Similar thing occurred with the post-intensive care unit syndrome in 2005. Still in 2024, in the journals of critical care, still there is a debate if post-ICU syndrome is something that could be with a single definition or something that requires also probabilistic definitions. So I have to say that I can live with this agreement. We only know 4 years of this disease. The virus is new. There is no doubt about this. We know a lot about other post-viral conditions. And for this, we started to know about long COVID or the other definitions of long COVID in about September 2020. So there is not even 4 years of knowing about this. In my modest opinion, I think that yes, it is a distinct disease because of the size of the problem and because the whole variety of sequela produced. I don't think that is a myriad of sequela of respiratory viral infection that can be attributed to having a respirator, being days or weeks or even months in the critical care unit. And my feeling is that long COVID is a new disease. And eventually in time, we will know about this. But I'm sure, Don, can I ask you, what is your opinion about this?
I think it's fairly unique. What we need to pin down is the pathophysiology. I think the syndrome itself is unique, and we need to know the molecular and cellular pathways that lead to long COVID. Again, that's a personal opinion. You handled most of the long COVID papers for the ERJ in the upcoming long COVID series. What should our readers expect to see from the original papers and review papers that will come out shortly in the ERJ?
Well, the good thing is that from the very beginning, the European Respiratory Journal has been very responsive to the needs of clinicians, both respirologists, primary care doctors that take care of respiratory patients, and allied health professionals. The first paper on COVID-19 that was published in the ERJ was already in March 2020. And to date, there have been more than 120 papers published on COVID or long COVID. Perhaps I have to highlight a few from the initial papers on risk factors or protective factors. It's not long ago that we know that the usual things that work in any respiratory virus, face masks, ventilation, hand washing, these were things that were good in minimizing the risk of infection. Also, some mechanisms. To me, this has been very extraordinary. I recall like 20 years ago when we were explaining in medical school that the lung parenchyma and especially the alveoli were points when it was like a surgical theater. There were no bugs, no bacteria, no virus. Now it's commonplace that we know that the alveoli, there is a lot of virus and a lot of bacteria in symbiosis with others. Well, for long COVID, to me, it has been extraordinary because just 3 years ago, we were thinking that long COVID was a consequence of the excess of inflammation that occurred in acute COVID, but that the human body was able to remove the virus from every organ. Now we know from autopsy studies, but also from long-term follow-ups of individuals with long COVID, that viral persistence in different body organs is something that plays a major role in many long COVID patients. There is not only persistence of the virus in the lungs and in the respiratory system, but also in the brains, in the guts, in the liver, in the bone marrow. And this plays a major role in each one of the three major phenotypes that we have for the disease. In the respiratory phenotype, second in the constitutive phenotype, and also in the cognitive phenotype associated with the brain fog, the anxiety, and the depression. But to me, the extraordinary thing that we know now, that at least there are 7 independent mechanisms that work in long COVID, that many of them have different windows of opportunity, and some of them not only overlap in the same individual, but change in the same individual. They are active, and a few weeks or a few months later, other mechanisms, including the autoimmunity or the resistance or sensitivity to the ACE2 receptors, they play a role in these long COVID individuals. So from the clinical guidelines, that is a living document available in the ERJ, led by our chief editor, Dr. James Chalmers, up to epidemiological studies of up to 3-year follow-up of some clinical series in China, or some clinical trials have been published in the ERJ. I have to say that on the clinical trials, the good thing is that we have been assessing more than 40 different clinical trials, which were randomized and with blinding. The negative thing is that up to now, only 3 clinical trials published in the ERJ were positive. Most of the ones published were or inconclusive or negative, probably because they were investigator-initiated, they were too small or too short in time. And the ones that were positive were to high-ranking medical journals, not specialized respiratory journals. But the good thing is that from the very beginning, there has been a lot of good information summarized in editorials and review papers in the ERJ, and in particular, the living document with the clinical guideline has been a tremendous resource for our readers.
Do we have a sense of what the natural history of long COVID is, given that we've had 3 years of experience, or is that still up in the air?
Well, there are more and more studies, and some of them from China, they are already entering the 4th year of follow-up. The natural history of long COVID, if we were able to plot it with an alluvial diagram, should have many branches. Especially, we know that after 4 weeks to 3 months after the acute infection, we see that actually most of the individuals that survive get rid of the symptoms. But from this deadline or this timeline of 12 weeks, 3 months, we see that or there is an increase in symptoms or there is a new onset of symptoms. These symptoms can relapse, can increase, or can fluctuate. And as I was mentioning before, there are the individuals that have one of the 3 phenotypes. The individuals with the respiratory phenotype that have shortness of breath, they cough, they produce phlegm, and that they are followed up with imaging or with a lung function test. Then there are the individuals with the cognitive phenotype mainly. Those are the individuals that have this brain fog, especially including children, not only that they cannot attend school, but even they have problems with playing by themselves or with their friends. And also adults that have this brain fog with anxiety and depression. And there is the 3rd major group of patients. They have the constitutional phenotype. These individuals have problems with balance, irregular heartbeat, an increase in blood pressure that is not related to exercise, and they have temperature or migraines that they cannot be explained by an alternative diagnosis. The important thing is that there are single individuals that they can have 2 or 3 of these phenotypes mixed together, but altogether with more than 200 syndromes. So probably the variety of signals and symptoms of long COVID is something that actually is new, even when we compare it to the post-viral syndrome with chikungunya, Zika, and other viruses. This variability is what makes it difficult to be identified and follow up both in primary care and in specialized respiratory settings.
For those who are still symptomatic, are there some management strategies that you can recommend, perhaps therapeutics or other types of intervention?
Actually, yes. There are several interventions that make a difference. The most important, perhaps, is the support and recognitions. Up to very recently, there were several doctors and some policymakers that were denying the existence of long COVID. They were saying that this is exaggerated by patients or that this is the consequence of an admission in the intensive care unit or being for weeks admitted in the ward. Patients are not inventing symptoms and signals. This is something that is producing a lot of individual burden, and already we have some strategies to reduce it or even to cure it. The number one is rehabilitation, especially for those with respiratory symptoms and signal. Rehabilitation works in these individuals. The limitation in exercise or the effort-related problems have to be customized in the day-to-day of these patients. And important is that they should do an exercise adapted to their capacity that does not produce shortness of breath, dyspnea. Respiratory care and rehabilitation is the first thing that these patients should do. Also, there are interventions like revaccination. The annual shots in individuals with long COVID, we know with very hard evidence that reduce the incidence of long COVID and also reduce the severity of long COVID. And in terms of drug interventions, there are two at least that have made a mark. One is Paxlovid, is something that again reduces the incidence and the severity of long COVID, and also the wonder drug, metformin. Metformin was one of the first drugs to be confirmed successful in acute COVID-19 that increased the survival of individuals with acute COVID-19, but in the US study that extended the randomized control trial of acute COVID-19, they also confirmed, and the paper was published in the New England Medical Journal and also in Lancet Infectious Diseases, that metformin reduces the incidence and the severity of long COVID. I'm also particularly interested in the cardiovascular polypill. The cardiovascular polypill is something that is being explored as a potential treatment for long COVID. It includes aspirin in a low dose and 100 milligrams, then an ACE inhibitor, and also includes a statin. These three forms of drug, they are effective in several mechanisms of long COVID. And specifically, if you add to this aspirin, ACE inhibitor, and statin, metformin, this could be very powerful in many patients with long COVID. First, because many of them, they have undiagnosed cardiovascular or metabolic disease, but also because many of these four drugs also affect several of the 7 mechanisms that are involved in long COVID. So I'm hopeful that this will prove effective in the future.
Well, we've covered a lot during this short podcast. Are there any final words for the audience out there who want to know more about long COVID?
In terms of final words, there are many things to say. And perhaps one is that we are moving from a pandemic to an endemic of SARS-CoV-2, COVID-19, and long COVID. The Institute for Health Metrics and Evaluation in the University of Washington in Seattle, in the United States, is saying that there is still a risk for new variants that could be more transmissive, more lethal, or could affect children. One of the things of these new variants that actually has been positive is that basically, especially because the ACE2 receptors are not so frequent in children as they are in adults, the COVID-19 and the long COVID exist in children, but are much less frequent and more less severe in children and adolescents as in adults. But we are still at risk that new variants could target children. So this virus and this acute and long COVID is here to stay. What we need is to get ready in case there is a revamp of this virus or we receive a new one. We have to be more prepared to have a good response that saves lives and that does not collapse the world as it happened in 2020 and 2021. So I'm sure that there will be more mechanistic studies, a longer follow-up of these patients, real natural history studies of the long COVID patients, and stay alert because this virus and new viruses are here to stay.
Very good. On that note, I want to thank Dr. Soriano for a very intriguing and interesting discussion on long COVID. Dr. Soriano's editorial on long COVID and related original and review papers can be found in the March and April issues of the ERJ at erj.ersjournals.com. Thank you.